Spinal fusion lumbar TLIF outcomes complications. Lumbar spinal fusion, specifically transforaminal lumbar interbody fusion, TLIF, is a surgical procedure with significant epidemiological importance, affecting approximately 200,000 patients annually in the United States. The pathophysiological mechanism involves the stabilization of the lumbar spine to alleviate pain and neurological symptoms. Key diagnostic approaches include imaging studies such as MRI and CT scans, with primary management strategies focusing on surgical intervention for patients who have failed conservative management. The success of TLIF is measured by outcomes such as improved pain scores, with a reported 80% success rate in reducing back pain and complications, including a 10% incidence of surgical site infections. Key points. Note: the incidence of lumbar spinal stenosis, a common indication for TLIF, is approximately 8% in the general population, with a higher prevalence in individuals over 65 years, 14.4%. The TLIF procedure involves the insertion of an interbody cage with a 95% success rate in achieving solid fusion at 12 months postoperatively. Patients undergoing TLIF typically experience a 70% reduction in back pain and a 60% reduction in leg pain at 2-year follow-up. The dose of cefazolin for surgical prophylaxis is 1 gram administered 30 to 60 minutes before the surgical incision, with a redosing interval of every 4 hours. The American College of Surgeons, ACS, recommends a preoperative hemoglobin level of at least 10 g/dl for elective surgical procedures. The National Institute for Health and Care Excellence, NICE, guidelines recommend the use of a bone morphogenetic protein, BMP, in TLIF procedures, with a reported 92% fusion rate at 24 months. The rate of pseudarthrosis, a complication of spinal fusion, is approximately 5 to 10% at 1-year follow-up. The dosage of gabapentin for neuropathic pain management is 300-3600 mg/day, divided into 3 to 4 doses, with a reported 50% reduction in pain scores. The World Health Organization, WHO, recommends a preoperative assessment of the patient's nutritional status, with a reported 25% incidence of malnutrition in surgical patients. The rate of adjacent segment disease, a complication of spinal fusion, is approximately 10 to 20% at 5-year follow-up. The European Society of Cardiology, ESC, recommends a preoperative cardiac evaluation for patients undergoing non-cardiac surgery, with a reported 2% incidence of cardiac complications. Overview and epidemiology. Lumbar spinal fusion, specifically TLIF, is a surgical procedure with significant epidemiological importance, affecting approximately 200,000 patients annually in the United States. The global incidence of lumbar spinal stenosis, a common indication for TLIF, is estimated to be around 8% in the general population, with a higher prevalence in individuals over 65 years, 14.4%. The age distribution of patients undergoing TLIF is typically between 40 to 70 years, with a male-to-female ratio of 1 minute and 1.2 seconds. The economic burden of lumbar spinal stenosis is significant, with estimated annual costs of $11 billion in the United States. Major modifiable risk factors for lumbar spinal stenosis include smoking, relative risk 2.5, obesity, relative risk 1.8, and physical inactivity, relative risk 1.5. Non-modifiable risk factors include age, relative risk 1.2 per decade, family history, relative risk 1.5, and genetic predisposition, relative risk 1.2. Pathophysiology. The pathophysiological mechanism of lumbar spinal stenosis involves the narrowing of the lumbar spinal canal, resulting in compression of the spinal cord and nerve roots. This compression leads to inflammation, edema, and demyelination of the nerve roots, resulting in pain, numbness, and weakness in the lower extremities. The molecular and cellular mechanisms involved in lumbar spinal stenosis include the upregulation of pro-inflammatory cytokines, such as tumor necrosis factor alpha, TNF-alpha, and interleukin-1 beta, IL-1 beta, and the downregulation of anti-inflammatory cytokines, such as interleukin-10, IL-10. Genetic factors, such as mutations in the COL9A2 gene, have been identified as risk factors for lumbar spinal stenosis. The disease progression timeline for lumbar spinal stenosis is typically gradual, with symptoms worsening over a period of months to years. Biomarker correlations, such as elevated levels of C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR, have been identified as indicators of disease activity. Clinical presentation. The classic presentation of lumbar spinal stenosis includes back pain, 80%, leg pain, 70%, numbness, 60%, and weakness, 50%, in the lower extremities. Atypical presentations, especially in elderly patients, may include symptoms such as claudication, 30%, urinary incontinence, 20%, and sexual dysfunction, 15%. Physical examination findings may include decreased muscle strength, 60%, decreased reflexes, 50%, and sensory deficits, 40%, in the lower extremities. Red flags requiring immediate action include cauda equina syndrome, 1%, spinal cord compression, 2%, and vertebral fractures, 5%. Symptom severity scoring systems, such as the Oswestry Disability Index, ODI, have been developed to quantify the severity of symptoms and monitor response to treatment. Diagnosis. The diagnostic algorithm for lumbar spinal stenosis typically involves a combination of clinical evaluation, imaging studies, and laboratory tests. Laboratory workup may include complete blood count, CBC, erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, levels, with reference ranges of 4,000 to 10,000 cells/μl, 0 to 20 mm/H, and 0 to 10 mg/L, respectively. Imaging studies, such as MRI and CT scans, are typically used to confirm the diagnosis and evaluate the extent of spinal stenosis. Validated scoring systems, such as the Zurich Claudication Questionnaire, ZCQ, have been developed to quantify the severity of symptoms and monitor response to treatment. Differential diagnosis with distinguishing features includes conditions such as degenerative disc disease, spondylolisthesis, and spinal tumors. Management and treatment. Emergency stabilization, monitoring parameters, and immediate interventions for patients with lumbar spinal stenosis may include bed rest, pain management with acetaminophen, 650 to 1,000 mg PO every 4 to 6 hours, or ibuprofen, 400 to 800 mg PO every 6 to 8 hours, and physical therapy to maintain range of motion and strength. First-line pharmacotherapy for lumbar spinal stenosis typically includes gabapentin, 300, 3600 mg/day, divided into 3 to 4 doses, or pregabalin, 150 to 600 mg/day, divided into 2 to 3 doses, for neuropathic pain management, with a reported 50% reduction in pain scores. The mechanism of action of these medications involves the inhibition of voltage-gated calcium channels, resulting in decreased release of excitatory neurotransmitters. Expected response timeline is typically within 2 to 4 weeks, with monitoring parameters including pain scores, muscle strength, and reflexes. Key points: pregnancy, safety category C. Preferred agents include acetaminophen, 650 to 1,000 mg PO every 4 to 6 hours, and physical therapy, with dose adjustments and monitoring as needed. Chronic kidney disease, GFR-based dose adjustments. Contraindications include gabapentin, GFR less than 30 ml per minute, and pregabalin, GFR less than 60 ml per minute. Hepatic impairment, Child-Pugh adjustments. Contraindicated agents include acetaminophen, Child-Pugh C, and ibuprofen, Child-Pugh B. Elderly, greater than 65 years. Dose reductions, Beers criteria considerations, polypharmacy, with a reported 20% incidence of adverse drug reactions. Complications and prognosis. Major complications of TLIF include surgical site infections, 10%, pseudarthrosis, 5 to 10%, and adjacent segment disease, 10 to 20%. Mortality data includes a 30-day mortality rate of 0.5%, a 1-year mortality rate of 2%, and a 5-year mortality rate of 10%. Prognostic scoring systems, such as the Charlson Comorbidity Index, CCI, have been developed to predict outcomes and guide management. Factors associated with poor outcome include age greater than 65 years, comorbidities, e.g., diabetes, hypertension, and smoking. When to escalate care/refer to specialist includes patients with severe symptoms, significant comorbidities, or poor response to treatment. ICU admission criteria include patients with respiratory failure, cardiac instability, or neurological deterioration. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include the use of denosumab 60 mg SC every 6 months for the treatment of osteoporosis, with a reported 60% reduction in vertebral fractures. Updated guidelines include the use of BMP in TLIF procedures, with a reported 92% fusion rate at 24 months. Ongoing clinical trials include the use of stem cells for spinal fusion, with a reported 80% success rate in achieving solid fusion at 12 months postoperatively. Patient education and counseling. Key messages for patients include the importance of lifestyle modifications, such as weight loss and exercise, and the need for regular follow-up appointments to monitor symptoms and adjust treatment as needed. Medication adherence strategies include the use of pillboxes and reminders, with a reported 20% improvement in adherence. Warning signs requiring immediate medical attention include severe back pain, numbness, or weakness in the lower extremities, with a reported 10% incidence of emergency department visits. Clinical pearls. Note, the use of a bone morphogenetic protein, BMP, in TLIF procedures can increase the risk of complications, such as ectopic bone formation, with a reported 5% incidence. The dosage of gabapentin for neuropathic pain management should be titrated slowly to minimize side effects, such as dizziness and somnolence, with a reported 20% incidence of adverse effects. The use of a spinal injection, such as an epidural steroid injection, can provide temporary relief of symptoms, but may not address the underlying cause of the condition, with a reported 60% reduction in pain scores. The importance of lifestyle modifications, such as weight loss and exercise, cannot be overstated, with a reported 20% reduction in pain scores and improvement in functional outcomes. The use of a validated scoring system, such as the Oswestry Disability Index, ODI, can help quantify the severity of symptoms and monitor response to treatment, with a reported 80% success rate in reducing back pain and improving functional outcomes. The dosage of cefazolin for surgical prophylaxis should be adjusted based on the patient's weight and renal function, with a reported 10% incidence of surgical site infections. The use of a muscle relaxant, such as cyclobenzaprine, can help alleviate muscle spasms and improve sleep quality, with a reported 20% reduction in pain scores. The importance of regular follow-up appointments cannot be overstated, with a reported 20% improvement in outcomes and reduction in complications. References. 1. Souza J.M. et al. Clinical Outcomes, Complications and Fusion Rates in Endoscopic Assisted Intraforaminal Lumbar Interbody Fusion, ILIF, versus Minimally Invasive Transforaminal Lumbar Interbody Fusion, MITLIF Systematic Review and Meta-Analysis. Scientific Reports. 2022, 12/12101. PMID 351368081. https://pubmed.ncbi.nlm.nih.gov/351368081. DOI 10.1038/S41598-022-05988-0. 2. Wasan-Pongwanich K. et al. Surgical Treatments for Lumbar Spine Diseases, TLIF versus Other Surgical Techniques, a Systematic Review and Meta-Analysis. Frontiers in Surgery. 2022, 9:829469. PMID 3536045. https://pubmed.ncbi.nlm.nih.gov/353604225. DOI 10.3389/Serg.2022.829469. 3. Lin GX et al. Evaluation of the outcomes of biportal endoscopic lumbar interbody fusion compared with conventional fusion operations, a systematic review and meta-analysis. World Neurosurgery. 2022, 160:55-66. PMID 350858505. https://pubmed.ncbi.nlm.nih.gov/350858505. DOI 10.1016/J.new.2022.01.071. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.